Welcome all to this new edition of the EMEUNET choice paper, selected by the EMEUNET community. My name is Polona Žigon and I'm a member of the EULAR-EMEUNET journal club team. Today we are going to discuss a paper recently published in Arthritis Research and Therapy. So let me introduce the authors of the paper, Dr. John Reynolds from the Rheumatology Research Group at University of Birmingham, and Dr. Nophar Geifman from the School of Health Sciences at University of Surrey. Hi, John and Nophar, welcome.
Hello.
Hi.
Your paper was selected for EMEUNET's choice paper. Congratulations for that, and thank you very much for your time and for sharing your results with us. Could you please introduce the title of your paper?
So our paper is entitled Distinct Patterns of Disease Activity Over Time in Patients with Active SLE, revealed using latent class trajectory models.
Thank you. So first, could you please tell us what was the objective of your study?
Of course. So the background of the study, as most people will know, is that there are a large number of negative clinical trials, particularly in lupus. And we currently design clinical trials as landmark studies where there's an outcome measure which is reported usually at 6 months or at 12 months. And we're looking for differences between the baseline and that outcome measure. But we collect data throughout a clinical trial at multiple time points, and patients often have very frequent visits during a clinical trial. And the way the trials are currently designed doesn't really take into account very well what happens to patients in between these landmark endpoints. So what we wanted to do was to use all of the data points within a clinical trial data set to see if we could try and understand what happens to disease activity over time. And this was one study that was part of the Master Plans Consortium, which was a large group of academics and industry partners funded by the MRC, with an overall aim to try and better understand and possibly predict drug responses in patients with lupus.
Thank you. Could you briefly explain to us what are the latent class trajectory models and why they are important to understand rheumatic diseases?
Yeah, so latent class trajectory analysis, or latent class mixed modeling, also sometimes referred to, it's a type of unsupervised statistical learning which can look at a very heterogeneous population and identify homogeneous clusters or classes based on some pattern over time. So essentially, each individual in the population is represented by a number of measurements over time, such as their disease severity score. And the algorithm identifies groups of individuals who display a similar pattern or trajectory. So the latent class mixed models offers a way to incorporating this additional level of heterogeneity, which can be used to uncover these distinct subpopulations and also incorporate correlated non-normally distributed outcomes and to classify individuals. So one will generally test several models with several numbers of classes, and then select the model that best fits the data using some objective measure, which allows you to select the best model in terms of fit. But also we tend to apply additional criteria, such as saying that each class has to have at least a certain percentage of the entire population. And that's just to make sure that the resulting classes that you end up with are clinically relevant and useful. And so too often in clinical medical research, we tend to look at patient outcomes at a single time point, for example, at the end of a study or at a 6 months time point after we start treatment. And we also tend to dichotomize outcomes. So we would say that a disease score of over X, that patient would be classified as a non-responder, but under that value, they would be classified as responders. And this is potentially oversimplifying a very complex pattern and the diversity in a population. And we're missing out on really important information. So as a technique, latent class trajectory modeling is used to explore these patient subgroups and stratifications in the population, enabling that precision medicine approach and moving away from that oversimplification of and categorization of patients. It's increasing in popularity with applications ranging from psychiatry to neurology, diabetes research and rheumatology more widely, and especially in areas where there's a need to identify groups of patients with varying patterns of disease progression or response to therapy.
Thank you. Very interesting. As we know, also in lupus trials, the choice of outcome measure is, of course, critical. What was your study population and how was lupus disease activity measured?
So the patients in this study were part of the Embody 1 and 2 randomized controlled trials of epatruzumab, which is a monoclonal antibody which targets CD22. And these were two large phase 3 multicenter controlled trials, and the data sets from these studies were provided to the Master Plans Consortium directly by UCB, and we had access to 75% of the patients in those cohorts. And the study was designed as a very typical lupus study. So patients had to fulfill the ACR criteria for classification criteria for lupus. They had to have a positive ANA or double-stranded DNA at recruitment. They needed to be on stable doses of immunosuppressants, and just like most lupus trials, if the immunosuppressants changed during the trial, that was considered a failure. And all patients, interestingly, had to be on steroids at recruitment, somewhere between 5 and 60 milligrams daily of prednisolone. Again, in common with pretty much all lupus trials, patients with active CNS disease were excluded, and patients with severely active renal disease were excluded. So in terms of the lupus population here, we've got an active population, but predominantly musculoskeletal and mucocutaneous disease with a few other lupus features. In the studies, the patients were randomized to 1:1:1 to either placebo or one of two different dosing regimes of epatruzumab. And what we did in this analysis was to combine all of the patients together, irrespective of which of the trial arms they were in. So try and maximize the data and to allow us to use this data-driven approach to the analysis. And we thought this was probably an okay thing to do in this context because the initial phase 3 trials didn't meet their primary endpoint. So we possibly were looking at a drug that may not work, and so it was probably okay to put the treated patients and the placebo patients in the same group, because of course placebo in a lupus trial doesn't mean placebo; it means addition to standard of care. And so all of these patients were on titrated doses of steroid along with standard immunosuppressants. As you alluded to in your question, the outcome is really critical in lupus trials. And for this kind of modeling, we really wanted to try and have a continuous variable which captured the breadth of lupus disease activity. And as you know, we don't have an equivalent of the DAS score. So we tried a couple of different approaches, and we felt that the best was to use the numerical BILAG score. So as you know, the BILAG score classically separates scores patients according to 9 different organ domains. And it gives you that very good granular assessment of what's happening in a lupus patient. But that can be converted to a numerical score. So categories where the disease is highly active with an A score have an equivalent of 12, and lower disease activity have low equivalents, and they're combined into a numerical score, a little bit more like SLEDAI. And we compared both the numerical BILAG score and SLEDAI in this cohort, and we found that the numerical BILAG score had a bigger range of values, and also it seemed to change more rapidly over the course of the trial. And so we felt that would probably give us slightly better sensitivity. But we do recognize that by doing this, we do lose the ability to compare what's happening in one domain to what's happening in another domain within the same patient.
Thank you. Yes. Okay, so you have developed the latent class mixture models to investigate the disease activity trajectories. So, and what was your main finding?
Yeah, so in this particular study, we were able to identify 5 groups or subtypes of patients based on their disease measure over time. These were broadly 3 main groups with 3 types of patterns. So we had a group of non-responders, a group of slow responders, and a group of rapid responders. But there were 2 additional smaller groups. One was the sort of high disease activity, and one which we called the flare group. But these were quite small, so they were less than 5% of the population, so potentially are less clinically relevant or useful, at least in this setting. Now, each one of these groups or classes was associated with a different set of clinical characteristics at baseline. For example, the non-responder group had lower rates of steroid use, and that could be related to the trajectory pattern that they displayed, or it could just be a confounding factor. It's something that's hard to determine from this type of study.
Yeah, so we heard that you had 5 groups of patients. Can you again share us which group of patients have been identified using these Latent class mixed models?
So as Nophar said, we found that there were 5 latent classes, but because 2 of them were small, we decided to focus on the 3 main classes, which were non-response, rapid responders, and slow responders. And there were no demographic differences between these groups, although it's important to recognize that the company weren't able to provide us with complete ages, so we had to consider the ages in age bands, and we weren't able to obtain ethnicity data. So that's an important caveat from that perspective. The patients that were in the slow responders and the rapid responders compared to the non-responders tended to have higher baseline disease activity and were more likely to have active disease in the musculoskeletal domain of BILAG and also the constitutional domain of BILAG. And for the rapid responder group particularly, they were more likely to have active disease in the cardiovascular and respiratory domain of BILAG. We didn't, however, find any differences in antibody profiles, which was a bit of a surprise. When we had developed these models, we wondered whether these could be phenotypes. So some patients with a particular antibody or a particular demographic may be more likely to get better more quickly, but we couldn't find any differences. So that suggests that there's something other than the patient's disease phenotype that's driving which latent class they belong to.
Yeah, thank you. Yes. So what relationship was revealed when between early changes in disease activity and latent class membership?
So once we'd identified that there were 2 latent classes that responded, a rapid response group and a slow response group, we wanted to know, well, how quickly are these people responding? And so we calculated the change in disease activity from baseline at every month for the first 3 months and compared them between each of those groups. And in the rapid response group, they had a significant reduction in disease activity by a month. So they really were responding quite rapidly. And by 2 months, that was kind of, across the whole population, that was as much reduction as they were going to have. And so from there on, their disease activity didn't really change that much during the study. In the slow responder group, there was a slow reduction in disease activity over the 3 months, and only really a small change from 3 months onwards. So it seems to suggest that in some patients, they do get better really quite quickly from having active disease. I think it's important to recognize that this was also reflected by the steroid reduction. And so it matched what we would expect to see clinically. So patients who responded rapidly tended to be more likely to have a steroid reduction. Patients who responded more slowly were perhaps less likely to have a steroid reduction. We also looked in an exploratory analysis at the CD19 counts, and there was a difference between the rapid and the slow responders over time. So the rapid responders, their CD19 count fell more quickly, and it separated out over the course of the study. But what was quite interesting is that happened much later than the clinical changes in disease activity. There was quite a significant lag. So I think that probably tells us that certainly in this context, the CD19 counts were not a good biomarker of what was happening to the patients clinically.
Okay. Did you maybe investigate if any specific therapy had differed between latent classes?
So although we talked about at the beginning that these were effectively negative phase 3 trials, we still wanted to look to see whether it was medication that was making this difference, given that we didn't see any major demographic differences. So you might recall that the patients received either placebo or 2 different dosing regimes of epatruzumab. And one of those regimes, the 1200 milligrams alternate weeks, there were more patients on that regime in the rapid responder class than would have been expected. And then we did a bit of an exploratory analysis by measuring the drug exposure using an area under the curve model, because what we found was that there was a huge variation in patients in how much drug exposure they had, irrespective of which of the regimes they received. And when you looked at the total drug exposure, that also seemed to be associated with being in the rapid responder class. But you'll be unsurprised to hear that in a lupus trial, steroids remain a huge confounder. And those patients who were in the non-responder group had a lower steroid dose at baseline, and they also had a lower cumulative steroid exposure. So what we did then was we looked at the steroid exposure during the first 90 days of the trial to try and account for some of the trial dropouts that occurred later on. And the exposure was independently associated with being in either of the 2 responder latent classes. And when we then developed a multivariable model, the epatruzumab was no longer independently associated. So the bottom line is that it's very difficult to separate out the confounding effects of steroids in this trial, but those patients that responded more rapidly were more likely to have a steroid reduction.
So considering these results, would you advise using disease activity trajectories when conducting future clinical trials?
So I think the short answer is yes. So disease activity trajectories can have a number of potential uses. So if you look at response to treatment, they can possibly help clinicians make decisions for patients. For example, which treatment is going to be best choice for them based on how likely they are to respond to that treatment. But having said that, we also have to make sure that any kind of decision support tool for clinical medical decisions need to be properly validated and further investigated before we apply that to real patients. With this type of study that we've applied to examine sort of disease progression and response in that clinical trial setting, they can be used to stratify populations to enable better clinical trials. In addition to this current study, we also conducted a similar analysis in a population of Alzheimer's disease patients from clinical trials. And in that analysis, we identified one trajectory of patients that rapidly progress in terms of their disease and their cognitive deterioration. And because Alzheimer's trials tend to fail, most of them at least, that could be a way of selecting those patients that are going to show some benefit if you were to test some new treatment or a therapeutic agent. So the answer is yes. Here in this study, our data suggests that you could identify a group of non-responders really early, so as early as 3 months, and then you could possibly use these patients to be re-randomized into the next mode of the trial, and then enhancing that efficiency and the cost effectiveness of the trial.
Thank you. So I'm sure our audience would really like to know also what do these findings add to the current clinical practice, and what is their value for our patients?
Yes, this is always a very important question. I think our data suggests that some patients with active lupus will get better irrespective of the treatment they're given. And it may be that some disease manifestations, particularly cardiovascular and respiratory, do get better more quickly than others. So I think we know that from our treatment of patients, comparing, for example, arthritis, which can resolve relatively quickly, to renal disease and proteinuria, which may take 12 months or longer to respond. So I think this kind of fits with that that message. I think most of our findings are quite relevant for clinical trial design, as Nophar already mentioned. And I think this kind of study suggests that an adaptive trial design where patients are identified as non-responders early and then switched to an alternative medication, and again followed, and then maybe even switched to a third, is probably feasible in lupus. And I think prior to, we weren't really sure that that would work in this patient context. In terms of trials as well, it highlights again that steroids are a really important confounder. And so we really do need to think about how we use steroids, both clinically and in the trials. And we probably need to think about greater reduction regimes. We need to think about much less flexibility in adjusting steroid doses over time. And we have to, of course, balance that against dropouts, because if we make the steroid regime too strict, more patients will fail the trial and drop out at that point. And I think the final thing that I think is quite interesting is that we did find really variable plasma drug levels, even though patients were receiving the same treatment regime. And I think, again, that suggests that maybe what we need to think about is treating to target, not so much treating to disease activity, but maybe treating to drug level in the context of trials, so that if patients are on a drug and their levels are low, their drug dose gets increased during the trial, so that we can be confident, or if we see a negative result, that it's not just because of pharmacokinetic variability within patients.
Thank you. So we are now at the end of this interview. Nophar, John, thank you very much for your participation and for sharing your really nice results with us.
Thank you.
We would again like to congratulate the authors and the rest of the team for winning the pool for EMEUNET's choice paper. We would also like to thank our community for their participation in the EMEUNET's choice paper pool, and invite you all to stay tuned to our social media platforms and to our upcoming edition. Thank you.
Thank you very much.
Thanks.